Hi, I'm Ali. I'm one of the physios from Treat My Achilles. In this video, we're going to be talking about a lesser known or well spoken about type of tear in your Achilles. It's called a longitudinal tear. And this is something that you would have noticed on imaging and have been diagnosed with. And if you have had that diagnosis, then this video will run through what is it, we can do about it, and what options you've got. So like I said, I'm Ali. I'm one of the physios from treatmyachilles.com. We're an online physiotherapy practice helping with any type of Achilles injuries. If you would like to look at what we do or find out any more information or book an appointment, please have a look in the information below. So what is a longitudinal tear? Well, longitudinal means it's going long ways compared to a crossways, so a transverse or horizontal tear. So if you were to think about an Achilles anatomy and imagine all of the fibres running down from top to bottom, and these fibres are bundles of collagen fibres all nice and lined up, and there's multiple bundles. If you were to look in the area where the tear is, you would see the tear running in that same direction of those fibres. It doesn't tend to then interrupt the border of the tendon, so either side, it seems in the middle, so it's called an intratendinous longitudinal tear. This image of an ultrasound scan shows that. If you are looking at the top part of the images with lots of white lines and black gaps in between, now that's an Achilles tendon, and it's normal to have black gaps in between those white lines. But if we look where those markers are, the little crosses, you'll be able to see they show an area of that tear. And that area of that tear is showing you that it's going in that same direction of those fibres. So a more readily talked about type of Achilles tendon tear would be a partial tear or a total rupture. And these types of tears, this is a type of partial tear, but one of the types that's mostly put into that bracket is where we tear going across. And that's what our other articles that we have written or other videos have referenced before. So if you are thinking that that is more you, please have a look at the information below. If you have just experienced something where you think it's a tear, so sudden pain, like a kick in the back of the leg kind of feeling, or a sudden popping, or something feeling like a gunshot's gone off, or someone's kicked you or hit you, a sudden amount of loss of function, so I can't push off, I can't raise up on my tiptoe on that side, or sustain being on my tiptoes, or something that's come on with real acute immediate pain, then this is something you need to go and see somebody about, and this is not what we're talking about in this video. We have got some videos on looking at what are the types of an acute type of Achilles tear and when you need to go and get some help. Again, they will be referenced below. So this is a relatively less spoken about, relatively less researched area. And what we know about longitudinal tears is about how likely we are to get them. There's a strong correlation between people that have had tendinopathies before and getting a tear. So what I mean by that is if we've got a tendinopathy, we're not strongly likely to get a tear. But if we had a tear, we're strongly likely to have previously had a tendinopathy or change in our tissues, even if we didn't know that was the situation. So when we're looking at tendon changes, and again, we've got an article based on that, and it goes into a lot more detail. If we again imagine that those fibres are all in those nice longitudinal lines, when we've got an area that's got tendinopathy changes, those lines are less delineated. It's a bit more higgledy-piggledy, and you've got a bit more of that space in between, which is some of the black gaps that you might see on that scan. If we've got that tendinopathy change, you may have symptoms from that, or you may never have had symptoms from that. And those sorts of symptoms relate to what we would traditionally call our typical Achilles symptoms. So the symptoms of an Achilles tendinopathy without a tear would be stiffness first thing in the morning when you're about to get up and take a step and walk and feel like you're walking like an older person, is sometimes how it's described. pain where you're getting it maybe at the beginning of an activity and then it warms up and feels more comfortable. Or if you get to the ceiling point of how much it can cope with, you then get pain coming on towards the end of activity. Well, that might not happen and you get a later on effect. So what you do that day tells a story over the next 24 hours about how much pain and stiffness you have. So if you suspect that you have a tendinopathy, then again, we've got videos based on this. Sometimes these tears happen without having had any previous tendinopathy, but they're in the minority compared to the ones that have had the tendinopathy changes, and then you see that tear there as well. Some of the research, like I said, it's not an amazing bulk of research that we've got out there, suggests this is more common in an athletic population or more younger population than what you may have seen in a tendinopathy traditionally. Now, again, I think that's probably a bit skewed because a lot of the data that's out there, the research papers, were looking at that cohort of people, and they were then taking that cohort and making suggestions on why they've got this change. So what we haven't got is a prevalence over a whole lifetime of different ages or genders of people, or active, inactive, sedentary, were active previously. There's no data on that information. How common this is a bit of a mystery, to be perfectly honest. Like I said, it's not been massively studied, and those studies swing from saying, well, 25% of people with Achilles tendinopathy have these types of tears, down to people saying, oh, actually, it's only about 4% of people with Achilles tendinopathy that have these types of tears. And this is because there hasn't been an easy way of detecting it or a standardized way of detecting it in each of the studies. They haven't looked at different definitions of what is a longitudinal tear, how big does it need to be, where is it, and therefore they've maybe not included the same criteria in each of the different studies. And that's where it's difficult to then say, oh, it's definitely there and it's really common or not. More research needs to happen to help us explain that. So how might you think, oh, I don't know if I've got one of these or not? Well, let's say you've had this grumbly Achilles tendinopathy that you've been dealing with those symptoms that we've just discussed. Then we've got a history normally, if we're listening to people, about a sudden overload. Now, what I mean by that is a sudden increase in activity levels. So that could mean I've gone out and instead of jogging, I've tried to sprint. Or it might be that I've done this amount normally every week of activity, and then I've suddenly gone and done a lot more. Or I've done not very much for a few weeks and I've gone back to my original activity level all of a sudden. So we're hearing this sudden change, this sudden increase in loading. It might be in one particular sport, or it might have been through multiple things that have happened. I don't know, something like a city break, a change of footwear, going out and running back-to-back days instead of a single day, and you went to an event where you were standing all night. It might be something where you add lots of pieces of the jigsaw together to create that sudden overload. So grumbly Achilles, sudden overload, and then a sharp, acute type of pain within that. And with that sharp, acute type of pain, the theory being that's when this smaller intratendinous longitudinal tear may occur. With some people, they're not even sure this has ever happened, so that doesn't necessarily happen with everybody, or you've been putting up with tendon pains for a while and haven't really distinguished whether there was that sharp pain there or not. Quite often, these symptoms have been grumbling around and persisting for a little while. It's not like you've just had this sudden pain on an irritated tendon and then gone to see somebody new. Sometimes this might have just been happening and you've been able to train and manage this quite well. And that training and management has meant that you've been able to tick along with all your normal activities, put up with the smaller little grumbles that are happening, but you've never quite got back to that last 10-15% of activity, propulsive movement that you were doing before this injury. So again, we're looking for the inability to get right to that top level of your normal level of activity. Sometimes this warm-up pain after rest is common, and that is also common in Achilles tendonitis, tendinopathy as well. So what I mean by that is I sat still for a while, I get up, it starts to feel a little bit stiff in my foot and my Achilles, and then I start to walk, it warms up and it goes off after a while. Why that's happening is when we're sitting, our circulation isn't moving as fast as it would do if we're walking. So we're getting a build-up of the irritant within our tendon. And then we get up, we start to walk, and we flush it away and it starts to feel better. And this is where imaging then comes to play. If you have had an Achilles tendinopathy, you might have gone for a scan. If you've had that history that we've just spoken about of a sudden sharp pain, you might consider going to find somebody to refer you for that scan. Types of scans can either be an ultrasound or an MRI. The image we showed earlier was of an ultrasound scan which can pick up longitudinal tears, but there is some evidence or some thoughts in the evidence that potentially maybe MRI might be better for that, because the ultrasound scan can show it, but sometimes it might miss it. So it's worth having a discussion with the clinician that you're seeing, or a referring clinician if you're not sure as to which type of scan might be more appropriate, or if you've already had an ultrasound scan, whether we need to look at something else. Do you need a scan? No, because as we come on to discuss what's going on with treatment, again, it depends on the individual. The treatment is not too dissimilar to what you would do for an Achilles tendinopathy anyway. There's just some subtle differences. So don't panic if you haven't had this diagnosed by a scan and you've started to do some other types of treatment for it. If things are improving and getting better, you're on the right track. If you're unsure at all, again, you need to see a clinician to find out what is the best option for you. And therefore, some of the information that we're doing here is for general information purposes and not specific individual cases. So what would our typical type of treatment look like? So we would be looking at conservative treatment in the first instance. So that's protecting it, not loading it too much to aggravate it, and then building up the strength and capacity of that tendon as things heal and get better. Again, quite a standard approach to an Achilles tendinopathy, but we're just going to be a little bit more cautious with that. So let's say you've just had that sudden onset pain, or we found out the diagnosis is there. What we would do is we would reduce any activity that's starting to aggravate this. So we said that you might be able to do, 80-85% of your activity, but have lost the top 15. Okay, well, we certainly wouldn't be pushing into that, but we'd also be looking at symptoms. When you are having any symptoms of your Achilles, what is it like over the next 24 hours? Anything that's an uptick of symptoms from doing that activity means we're probably going to change it. And it might be that instead of running 5K, for example, you might be running 3, or you might be going for walks instead of runs. Instead of walking for 3 hours, you might be doing 2 one-hour blocks, for example. And again, we're looking for that 24-hour pattern. If it's really acute and it's quite irritated and sore, it might be that we're having complete rest for a period of time. And again, that's where it's important that you speak to a clinician. It's not a one-size-fits-all. We'd also stick some wedges into your shoe, so something like a heel wedge or raise, and this would lift you maybe a couple of centimetres, and that's enough to bring your heel slightly higher. So if we're thinking about the tear, we're bringing the edges of the tear closer together by doing that, as opposed to further apart by trying to stretch that heel back. And that's why we don't like tending to go into that eccentric bias. So we'd put the heel in to shorten the calf and the Achilles, to offload it, make it feel more comfortable, but help promote healing. And at the same time, we would not be stretching. So we wouldn't be going into strong Achilles stretches, doing anything off a step, looking at activities like downward dogs or planks or warrior positions in yoga, lunges, things within any kind of other sports that would put you into that stretch type position. And again, we'd be eliminating those out for the first couple of weeks. Once we're at that point and things have been adapted and the things are settling and becoming easier, so that 24-hour pattern has started to become more comfortable, or it's now really comfortable day to day, we would then be reducing that heel lift. So we're starting to gradually take it out, and it would take it out over a couple of 3 weeks, depending on your symptoms. And as we're reducing that, what we're trying to then do is get you to be back on a normal position, so you're not ending up with tightness in that calf. During this time, because you've got yourself in a little heel wedge, you're not able to walk and push off as easily as you were doing. You might get feelings that your calf is quite tight. And if it's feeling a bit tense or a bit tight, then that could be used to be massaged or foam rolled or dry needling or heat packs, anything like that that you find is comfortable. What we would not do is treat that Achilles tendon by prodding it, poking it, massaging it, sticking things in it, because again, what we're trying to do is get that to settle and calm down and not really press on it enough that we're starting to set off back that irritation again. We would then start to do some strengthening exercises, particularly more on that way up movement. So it might be that we're doing isometric holds to start. So isometric holds are where you raise up onto your tiptoes and then hold for a period of time. Or we might be starting to do gentle calf raises from the flat floor and see if we can then progressively make those difficult over time. So if we think about a rehab pyramid here, we've got calm things down and reduce any inflammation or irritation because of that acute pain from a tear. Offload it so we give it the best chance to heal. Start to build up the strength in a comfortable range of movement that you can manage, but progressively making it more difficult over time. Examples could be going from the holds to the up and downs, which could be on 2 feet, then 1 foot, then with weight, for example. But again, it depends on how you are, how strong you were before, what equipment you've got access to, and what sort of type of tear have we seen on this scan. So again, it needs to be clinician-led for this point. We'd also be looking at weighting these exercises now, so you doing the exercises with extra weight, if that's at all possible, looking to fatigue those calf muscles, again, as long as it's comfortable. So rule 1, is it pain-free and comfortable? No uptick in my normal amount of symptoms for the next 24 hours. Rule 2, could I do those exercises well with good control, good technique? Rule 3, were they easy? Were they in my wheelhouse? Did they make me feel tired or my muscles tired? Well, if it was comfortable and if it was easy and it was in your wheelhouse, you're not getting stronger, you're just maintaining. So we need to push that boundary and move forward. So once you've got your load with your weights, we'd then be looking at, can you jump? Can you hop? What are your goals? If your goal is not to jump and hop, you're happy just walking your dogs or going around the golf course, we might not look at that part. If you're doing a sport where you need to twist, turn, change direction, move, jump, whatever, we need to look at that part. And then we'd be doing our gradual return to sport and phasing in that so we don't get that sudden overload of symptoms. So like we said, most people get better by these conservative management. Well, what if we're hitting a bit of a plateau? What if this isn't quite working for you? What other options have been studied and what is something we might consider? Well, we found a single case report. So that's a case report of one person having really, really good experience with PRP injection. Now, this PRP stands for platelet-rich plasma. What that is where they remove some of your own blood, they take it, stick it in a centrifuge, which is something that spins it really fast, and then they remove that platelet-rich plasma, turn it again into a little bit more spinning into a protein liquid, and they inject it into that tendon. And where they inject it, the idea is that it's promoting that healing and helping it to knit back together again. Now, the case report was an indication of somebody with a 4 centimetre intratendinous longitudinal tear. So 4 centimetres in length, intratendinous in the middle, not near the edges, or not going into the edges, longitudinal, same line as those tendon fibres. This single case study report showed that there was an 80% improvement pretty quickly. I'm just looking as to how quickly that was in 1 month. So very quickly, by looking at this from one scan, having the injection, and then having the scan again. And they were saying in 3 months, which is our 12-week program, you're also looking to see that that was full resolution. Now, if we're looking at doing this alongside our rehab, we would also be talking about a similar timeline. So you have to be looking at, this is a single person. Can we transfer this to every person that's ever had a longitudinal tear and expect them to behave in the same way? Absolutely not. But it does indicate that more research in this area would be really valid and something to look into. So don't rule it out, but also don't rule it in. And it's something to discuss with a clinician, particularly if that conservative management isn't going the way you'd like it, or it's hit a bit of a plateau and not moving on from there. Is surgery ever relevant? Well, it's not studied at all. There's been 0 studies comparing the outcomes of surgery versus the outcomes of doing the exercises and the conservative management, or comparing that to injection therapy. So there just is a big gap in the research for longitudinal tears here. I certainly wouldn't be advocating surgery until you've explored all of the other options, or if your symptoms are persisting despite doing all of those other options, or your tear was significant, i.e. more than 50% of the length of your Achilles tendon, then it would be useful to get a surgeon's take and their information and their guidance on this. So again, this would tend to be a diagnosis having done post having had an MRI or an ultrasound scan. So typically that would then be casting an eye over from a consultant or surgeon, and they would be able to give you their specialist opinion in that. It's also something that might be more likely to be used in an athletic elite sport population, particularly for those that have not yet been able to get back into that high load or that high level of activity. If you think this might be something that you have an issue with, then it is worth again speaking to a clinician and seeing what is the best route forward for you. Thank you for listening.